Welcome back to the Philips African Dialogues. Well, this week, of course, we're taking a closer look at non-communicable diseases in Africa, including the strategies needed to help address this looming healthcare pandemic. And before we get into the solutions, because of course this ranges from technology, it ranges to incentivization, I just wanted to touch on some interesting stats that I saw coming through from the US when it comes to the burden on medical aid, and basically saying that those with multiple conditions, so looking specifically at people who had more than 6 NCDs, pretty much, so very unhealthy people is what you're looking at, accounting for 12% of those on Medicare. So 12% of those on Medicare have 6+ multiple conditions, and they account for 43% of total spending on healthcare. So what that really shows from a medical aid perspective is how costly unhealthy people are on the total healthcare industry. Is that your experience here? No,
definitely. It's an experience here in South Africa in our private healthcare, on the basis that out of the 100% of the people that are covered, there's about 20% that we call them, they are high claimers. And in most cases, you find that those people have got comorbidities. As you know, if you've got hypertension, there's a likelihood that you end up with diabetes. And when you've got diabetes and hypertension, you are most likely to develop chronic renal failure. So already there are 3 conditions that lead to one another. And all those, they're all related to lifestyle diseases. So therefore, I think the high claimers are the biggest cost drivers in healthcare. And if we can be able to deal with these issues of NCD or non-communicable diseases, that will also bring down the major cost of the private healthcare.
Which makes sense why the health minister chooses to focus very much on this aspect, because ultimately it reduces the economic burden on South Africa, more productive workforce as well. Let's get into the solutions. Firstly, starting from your side, JJ, I mean, very involved in a specific project in Kenya right now. Tell us about what you're doing in that front.
That specific project is about how we can reduce mother and child mortality, specifically how screening with ultrasound in a more rural type of setting can actually, and transferring that images through a mobile network to a central diagnosis station, and returning the image back and the outcome back, you can actually pre-diagnose that there are complications developing. As we all know, the Millennium Development Goals 4 and 5 indicate the mortality rates of mother and children, and that's been really quite significant, and we haven't really fully addressed the issues completely at this point in time. But we believe that by using simple ultrasound scanning, we can actually have a material impact in terms of mortality rates. And that is really quite significant, because we have a firm belief that every mother is important in society. They are the center of the fabric of a family. And not having a mother dying through complications, you actually are depriving a whole family and a whole society of further growth. So it's about using equipment and the technology in a wise way, transferring those images elsewhere, diagnosis of those images and referring back and addressing the issue early, before the mother comes into childbirth, and you then have a complication developing.
So where are these images transferred to?
They're transferred from a rural clinic, for example, to a central diagnosis station via mobile networks, etc. And that information is then diagnosed by a specialist, assessed by a specialist, and then in the complication cases, we give back information back to the rural clinic of how to treat, and you're then aware that there's a complication that's actually developing.
Is this model the one that is the most likely to be, replicated in Africa? Does it make sense to have, specialists look at it off-site? Because we were talking about it, but it also involves the technology aspects. It involves having those specialists there and getting the information back in a timely manner.
Yes, I think it's an applicable model, but we have to consider what technologies do we have for non-communicable diseases, and what new research do we need in terms of the appropriate technologies, and also the scale up of existing technologies. We have, for example, existing vaccines for liver cancer and for cervical cancer. These are cost-effective vaccines, and they should also be scaled up to prevent these 2 of the most important causes of cancer in the continent.
What are your views on those 2 issues there?
Well, basically, as you say, prevention is quite a most important intervention measure. And within Bonitas, what we have done as a preventative measures, we have established the health professional networks. And these networks of professionals, we are able to utilize them to ensure that, I mean, when they are being part of the scheme or part of the fund, they are able to ensure that they can treat our patients quite early before they can go into hospital. And we've also demonstrated in our studies that we have been able to reduce the hospital admissions, and we've also been able to reduce the number of days or the length of stay in hospital by those kind of professionals.
So partnering with your local GP is what you're saying?
Definitely.
What's the incentive for the GP?
Well, the GPs they are then scored according to the quality of care that they provide. And therefore, the ones that are more cost effective, they are then reimbursed much at the higher level. And the ones that are not being cost effective managers of healthcare, they are then peer reviewed through their own colleagues, because it's always better to utilize the services of other doctors to peer review the other doctors. Therefore, then that particular doctor is then being able to uplift it to another level whereby he's more cost effective in terms of ensuring that healthcare it's managed at a much more cost-effective manner.
Dr. Ola, give us an indication of, let's talk about medical aid in Nigeria right now and the penetration of medical aid. You know, I've got stats when it comes to the East African region, and you know, very underpenetrated. Is this the case in Nigeria? What are some of the trends that you're seeing when it comes to medical aid coverage?
Yeah, in Nigeria, actually, most of the payments for medical care is done by out-of-pocket payments. But there are about less than 20% of Nigerians have medical insurance. And most of those who have medical insurance are those that were employed in the formal setting. However, some states in Nigeria, like Lagos State, has begun a community-based health insurance scheme in which community dwellers are made to pay a premium, and then they're able to access health care, you know, based on that. However, this has just been test run in 2 local governments in the state. There's a need to encourage other local governments to adopt this process. And even in the larger society, there's a need to encourage other states of the nation, because with the increase in the prevalence of non-communicable diseases, we know that poor families are further impoverished by the cost of payment of healthcare, as well as the cost of maintaining family members with non-communicable diseases like hypertension, stroke, diabetes, and all of that. So in Nigeria, there's a need to improve on our healthcare insurance policies.
I mean, do NGOs come into this space when it comes to a budget going towards this? Because communicable diseases in Africa have certainly come to the fore and taken the spotlight when it comes to NGO focus. But is this becoming an area that they focus more and more on?
Well, for some diseases, but for most of the diseases like hypertension, the body is based on the patients themselves. They have to care for themselves as regards their hospital bills, as regards their drugs, as regards their investigations. So most of the NGOs around are focusing on, you know, most of the NGOs in Nigeria, they just carry out vertical programs. They don't do an integrated program. And this is one of the ways which we are telling ourselves that we need to improve on. Rather than having vertical programs, we need to integrate, because the person that has HIV also has hypertension, he has diabetes, he has other non-communicable diseases that will also put stress both on himself and on his family. So most NGOs in Nigeria are really not focusing on these non-communicable diseases that are of concern to us.
It seems like a narrow-minded approach, and the approach needs to change. I mean, are they appreciating it? The NGOs that you are aware of, is there an understanding that the whole mindset needs to change, basically?
Yes, I think there is increased awareness among the NGOs, the civil society. And in fact, we've had several summits, a UN summit in 2011, in which we tried to get NCDs higher on the development agenda in Africa, in recognition that this is a problem that we must face.
Does that mean, you know, MDGs, Millennium Development Goals, need to have NCDs as one of the kind of, you know, goal in there in terms of a target?
Well, I think among the discussions among health professionals, it may be best to look at concepts like universal coverage. Universal coverage is a concept and a commitment that most governments have committed to, where they've committed to ensuring that everyone has access to health care for their health needs, regardless of the ability to pay. And this is a concept that can be used and adapted across countries, regardless of the burden of disease.
This issue of affordability of healthcare is really coming to the fore, and you know, how can the private sector play a role here? Do you see opportunities for the private sector, JJ?
Yeah, I certainly do see. From us as a company, it's about how do we actually focus back on the rural community, or the rural community and the rural healthcare worker, how we can build appropriate technologies there, because we've heard the discussion up here. We talk about diabetes, we talk about blood pressure and all those type of areas there, and there are ways that those home healthcare workers, if we provide them with the appropriate tools, can actually address there. That then makes it more affordable for the whole healthcare system itself, because 500 million people are without access to electricity. And in rural type environments, and we've got to address on those type of people as appropriate compared to just maybe the urban population groups at this stage. So in last week's World Economic Forum discussions that we were in, it was very interesting just listening to the discussion post 2015 Millennium Development Goals and what needed to happen, because part of the focus was we need to move back to the rural healthcare person. We need to find the solution that is needed at that point. We heard NGO groups talking about how important it is in terms of treating the patient in their home, their community. The local doctor or the local home healthcare worker has far more understanding of the community and how the individual fits in their community and their needs of the individual in their community, and those things can be picked up right at that point.
How affordable currently, I mean, is the technology that you have specifically in the screening space for Africa? I mean, give us an indication of whether it's appropriate cost-wise.
I think we obviously have the full range of equipment. As a company, we have the full range of equipment. So we can do everything from ultrasound through to MRIs. I do believe that as a company, we have a responsibility to also to focus more closely on what is needed in this type of market. And that's part of the reason why we're doing these type of programs in Kenya and Uganda and elsewhere, where we're trying to assess what is really needed in the more rural healthcare setting. Now, I don't believe we've cracked the solution at this stage, but I believe there's a firm commitment from the company to actually invest more in terms of technology, use of applications that can actually apply as opposed to hardware.
Yeah, the software side of it, you know, of course. Is there
simple collection of the data. In many cases, we see paper systems are still used in these rural communities. So simple use of software to collect the data, to bring it appropriately to the right professional at the right level in the healthcare system.
Data, of course, is very important to medical aid companies. I mean, what's your experience in terms of, you know, the developments that are taking place right now to improve data collection in South Africa and Africa more specifically?
Well, as a scheme, as you know, when you are dealing with a scheme, the most important thing is data, as we've mentioned, and IT systems. We make sure that on a regular basis we upgrade our IT system to the level that we can be able to collect data, and we should not only just collection of data, it should be collection of quality data that actually talks to the kind of ailments that you are facing, how to intervene on them, the trends that are happening with those particular ailments. I mean, we're talking now about the NCDs. I mean, it's important to know in a particular area what is the percentage of the hypertensive, the diabetics, or even the chronic lung diseases. In that way, you are able to package your benefits such that they intervene at the areas of most important. For example, hypertension is the most important one in our case, because it covers close to about 12% of our members. Therefore, with correct data, we are able to come up with more cost-effective measures in terms of ensuring that you negotiate the best cost-effective medicines at the cost-effective prices as well. So in that way, you are able to manage your cost better for your members at the end of the day.
I mean, you can only really take the right action if you have the correct information to act on. Who's responsible? I mean, which players are responsible here for ensuring that we get more accurate and reliable data coming through from Africa?
Well, I think the governments have taken on this responsibility in terms of setting up surveillance systems, for example, for monitoring behavioral risk factors, including smoking, alcohol use, as well as biological risk factors, hypertension and diabetes. And I think this is critical. One of the difficulties is that we have not known the scope of the problem, and so data is critical to inform the problem.
But I suppose the scariest number we saw at the beginning was that NCDs are ultimately going to take over from communicable diseases by 2030. So there is kind of some broad numbers coming through.
Yes, absolutely, based on surveillance systems that are existing. But they could be strengthened and they could be expanded.
And what's the Nigerian experience when it comes to investing in surveillance systems, in data collection systems that are accurate and, as you're saying, reliable here in studio?
In Nigeria here, we have hospital-based records where we have data collection, we have departmental data collection tools where all patients with non-communicable diseases are being registered in. However, because we also have an enormous group of traditional healers, those who patronize these traditional healers don't have the opportunity to, be included in the data of those with non-communicable diseases. This gives us like a lesser information as regards people who have hypertension, people who have diabetes and all of that. So the figures we have are usually estimates, and the WHO estimated that about 818,000 people, 818 men out of 100,000 have cardiovascular diseases. However, it varies, because from states to states, because of the patronization of the traditional health, traditional health healers.
I mean, those are some scary numbers there when you're talking about, the prevalence of cardiovascular disease, cancer we know is rising. But let's get back to some of these innovative solutions. So we talked about screening, we talked a lot about prevention. I mean, what really stands out for you? Some of the ideas that have been put on the table, some are still being worked on, but what are some of the best ideas that have come forward?
Well, WHO has put forward a series of best buys, or essentially the most cost-effective interventions to addressing the NCD burden. And these include tobacco control, control of the harmful use of alcohol, reductions in salt intake, and promotion of
we'll get back to that. Don't worry.
One more. Yeah. Oh, essentially the one I mentioned earlier in terms of vaccines. So vaccines. So vaccines, particularly for liver and cervical cancer.
But community becomes also a very big player in the new take on looking at NCDs. Yes. Are you involved in training here because I mean you've got equipment out in rural areas that need someone to manage and someone to be able to provide that healthcare?
I think we see it in a number of aspects. One is in terms of the actual equipment that will be used for this type of screening program and the training with that. Also, we have a program running at this stage, Cape to Cairo, where we are focusing on training of professionals, making people aware, re-educating of healthcare professionals, nurses, midwives, etc., in terms of what is best practice, what is opportunities where they can improve on. Last year, I think it was more than 1,200 we trained during the period of the 3-month program. So there is opportunities to do that. In terms of the equipment itself, a key view from us as a company is that if you provide any screening equipment, you need to make sure that it is fully operational. And therefore it's training both of the person who's going to use the piece of equipment in terms of the right practice and the correct operation of the machine, but it's also having the right engineers on the ground to support that. And if you do that, you can have very high up times in terms of equipment, because there have been signs from the World Health Organization that more than 50% of diagnostic equipment across Africa is not fully operational. And we firmly believe it's because of this whole focus that needs to occur in terms of making sure that there are trained technicians available, that there's a longer service contract associated with equipment, as opposed to just focusing on buying the equipment or having equipment donated.
And there's a massive shortage of skills though when it comes to engineers and these types of technicians in Africa. How do you get around that issue?
What we tend to focus, whenever we sell equipment, we focus on a package, including the service. So whether it's here in South Africa, where we have our own big organization in terms of servicing, or whether it's with a distributor organization in another country, we can support them from here. But we also believe that our own distributors should invest in their own workforce to support the ministries of health. A key part of our program over the last few years has been working with ministries of health in terms of revitalizing the healthcare system. And a key part of that is that when we discuss with them, it is about this whole aspect. It's not just about the equipment. It's about the actual training of professionals. It's about the training of engineers and supporting it. And if you have a clear plan, as was mentioned by my colleague, you will actually see that these programs can be very successful. And so therefore, to me, it's about a clear plan and a well thought out plan and making sure it's sustainable more than just the initial implementation.
You know, there are a lot of medical aid schemes right now that are incentivizing healthy habits. You've talked about, you know, trying to communicate that to your members, trying to educate them. But is that in your plan?
Yes, no, it is in our plan. Also and above that is that, I mean, as a scheme as Bonitas, we are actually been sponsoring the Pretoria to Johannesburg Marathon, whereby we incentivize some of our members to participate, because with exercise...
Do you reward good behavior though? I mean, is that something that you could do? No,
definitely. That's what we do, because I mean, in pay points or areas whereby we see that there are certain behavior patterns that demonstrate that there's an increase in NCDs, we ensure that we intervene there and encourage wellness programs, that getting people to be detected early, making sure that they take their medications regularly. And those pay point areas that we visit, normally in our next visit, we are able to ensure that, I mean, we are able to see it that, I mean, there has been an improvement in terms of what intervention measures that we have done. And also, I mean, participating in a big marathon called Comrades Marathon in Durban.
You're a Comrades marathon runner?
No, I only support them. So basically, although I'm not a Comrades runner, but I'm a recreational runner. So I can only run up to about 15 kilometers.
Well, that's certainly further than I can.
So, I mean, those kind of behaviors, I think they are the ones that can actually assist our members of the community to live those healthy lifestyles, because it's all about behavior modification. I mean, some of our people, we know that they like watching their favorite station or their favorite programs on TV, and we encourage them that while you are watching your favorite program, just put your, whether it's your stationary bicycle, you cycle while you are watching your favorite program. So those are some of the innovative measures that we advise our members, or some of the things that they can do to ensure that they can avoid these NCDs crippling their lives in the long run.
When it comes to diffusing technologies into, you know, on a broader scale, basically, more accessibility, what are some of the ideas that are being put on the table when it comes to financing this, creating incentives for investment from the private sector to scale up the provision of these innovative ideas?
Well, I think most health successes have been partnerships with across government sectors, with private sectors, with civil society. And so I think that essentially what we've seen is a rapid scale up, particularly in South Africa, of very innovative health technologies, particularly for TB and HIV. And so I think the very same thing can be done for NCDs. Of course, it has to be affordable and it has to be appropriate for the local condition, but I see no reason why simple technologies that are available in particular cannot be scaled up, particularly for primary care level.
But from Philip's perspective right now, you see this as an area that warrants R&D, warrants R&D spend, warrants focus specifically.
Yes, I think from the healthcare perspective, how we screen, etc., we see more focus there. But what we have, as an example of a related technology, we've just released and we've started a factory in Lesotho for wood stoves, smokeless wood stoves. Respiratory disease is a big issue that occurs in Africa. So we've used the highest level of technology with fans in a stove, where you can burn anything from dung through to wood chips to pellets, and you have a very low percentage of smoke that is generated because of the technology that's used in the product. So therefore is an example of a high-tech product that is available for the consumer in the more rural area, and that's something that we're pushing forward through now in terms of going into full production with as an opportunity to actually really make a difference to people's lives in rural communities.
Let's just go back to Nigeria because you're spending a lot of time here talking about all the other options on the table in South Africa, in Africa more generally right now, to addressing this issue. So, Olan, how do you take this forward right now? I mean, where's your specific area of focus, and where do you see the government of Nigeria needing to focus their energy and, I suppose, budgets to deal with this crisis, which, as you said at the beginning of the show, is becoming more and more of an issue?
Yeah, the Nigerian government has to integrate the healthcare service, has to make sure that the primary healthcare facilities that are being provided for the people are able to catch the non-communicable disease early enough. More screening opportunities for those in the rural areas. Also, in terms of manpower, human resources has to be strengthened. We have to have more technology in rural areas, because the urban area is actually flooded with healthcare providers as well as services. But those in the rural areas, which also add to the indices of the country, are left behind. You know, so we have to put more efforts at providing their health care, you know, screening for them, health education, health promotion of healthy ways of life. Those modifiable risk factors of non-communicable diseases can be dealt with. Alcohol use, cigarette smoking, you know, physical activities, you know, and all of that. They need to be tackled in those rural areas. Also, as regards to education generally, because I think that when someone is educated, then the person has better choices, you know, has better opportunities to make good choices. Yeah. So those areas, the Nigerian government has to, you know, put in more efforts.
Well, it certainly does just extend to all the other countries that we've spoken about in Africa, and South Africa, of course, here. Thank you so much for joining us all today. We've come to the end of this edition of Philip's African Dialogues. Thanks, of course, to my guest, Dr. Sarah Barber from the World Health Organization, JJ van Dongen from Philips Africa, Dr. Bobby Ramazia from Bonitas Medical Fund, and from our bureau in Lagos, Dr. Olan Rawaju Ikpika, the representative for the Department of Community Health and Primary Care in the Lagos State. Until next time, stay healthy.